Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from the Portugal, Professor Oscar Alves. He is the head of neurosurgery at the Hospital Lusíadas, Porto, and he is a senior consultant in neurosurgery at the Centro Hospitalar de Gaio Espinho. He was a previous Fulbright Fellow and he is the co-chairman of the International Academy of Spine. His clinical interests are focused upon spinal diseases including spinal tumors and degenerative spine. And we are extremely grateful to him for accepting our invitation to be a speaker at today's webinar. And today he'll be talking about sacroiliac joint pain and MIS fusion, a neglected topic in spine. The speaker for the second session of today is our honorable guest from China, Professor Xia Lei. Dr. Lei is the Chief Surgeon and Deputy Director of the Department of Neurosurgery in the first affiliated hospital of Wenzhou Medical University, China. His clinical interests are focused upon the management of complex skull-based tumors, and we are extremely honored to have him with us to be a speaker for our webinars. And today we'll be talking about surgical management of tumors of the cavernous sinus. The chair for the first session of today is our distinguished faculty from the USA, Professor Mohammed Abdul-Bar. Dr. Abdul-Bar is an associate professor in neurosurgery and orthopedics in the Division of Spine at the Duke University School of Medicine, Durham, South California. He is an expert in the field of treating patients with spinal disorders with minimally invasive surgical techniques. This includes spinal stenosis, listhesis, scoliosis, herniated disc, and spinal tumors. He also works with the Duke bioengineers and neurobiologists on important basic and translational questions surrounding spinal cord disorders. We are extremely honored to have him today to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from Japan, Professor Takashi Sugawara. Professor Sugawara is a professor of neurosurgery at the International University of Health and Welfare, Narita Hospital. His clinical interests are focused upon skull-based surgery and craniofacial surgery. He has published extensively on the cavernous sinus tumors and is an important member of the Japan Neurosurgical Society. He has published several articles in various leading journals and book chapters. We are extremely grateful to him for accepting an invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Gato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. We are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this podium to our first chair, Professor Mohammed Abdul-Bar.
Good morning, good afternoon, and good night from wherever in the world you're joining in. It gives me a great pleasure to be here with all our colleagues and friends. First of all, I'd like to thank Dr. Raja for this nice webinar and the introduction and giving us this opportunity. First speaker, it gives me great honor to introduce Dr. Oscar. He's a well-known figure in spine surgery, and I think he's going to talk about a subject that is really important. I think as more and more of us are doing more and more spine surgery, we're realizing that adjacent segment disease doesn't necessarily have to be above your construct, but the next joint is the SI joint, and this is something I think that his topic and his subject of a neglected manner is very pertinent, and I'm extremely looking forward to learning about that. So, Dr. Oscar, with no further ado, please share your slides.
Okay. Once again, it's a really great pleasure to collaborate with the ACNS on the webinars. I would like to thank Professor Kato and also Raja and Liu for organizing and Mohammed for chairing this session. So my topic is sacroiliac joint pain and MIS fusion, which I think it's a neglected topic in spine that we need to pay attention. I have no disclosures for this presentation. And if you look at here, the trends over the last 10 years in citations and publications, you see that after 2015, there was really an effort in the topic, but in my opinion, not yet still very, very popular. The same, again, the number of devices that have been implanted, there is a steady growth, but still much way to pave. There were really two papers that were eye-opening for me. This sacroiliac joint, an overview of anatomy, functional and potential clinical implications, and this paper on IGSS on the biomechanics of the sacroiliac joint. And I would advise you to refer to those journals. It's really important to get a sense of what is this topic. So talking briefly about anatomy and biomechanics, this is one of the largest joints of the body. It has an anterior third that is truly a synovial joint, and the posterior two-thirds are stabilizing ligaments. It is essential for effective load transfer between the spine and the lower extremities. It can work as a shock absorber for spine above. And obviously, if damaged, low back pain will come out. It is innervated by mechanical and nociceptive receptors. And the innervation comes from ventral rami from L4, L5, superior gluteal nerve, dorsal rami from L2 to S1. So in a way, there is a convergence of sensory pathways from hip, from sacroiliac joint, from lumbar pain, which make it difficult because to identify a specific pain generator and semiology. And this is, I think, part of the problem because there is an overlap of symptoms and patterns. The movements of the sacroiliac joint, it's as you see here, notation 2 and 4 millimeters, an anterior tilt, counter notation, posterior tilt, and some kind of torsion in the transverse plane. It's not a really mobile joint. The motion is about 1 or 2 degrees, for example, torsion. But if you have motion like 3, 4, 5 degrees that you cannot see on any X-ray, but this causes really pain, very, very intense pain. And these are the active movements that stress the sacroiliac joint: forward flexion of the spine, extension of the spine, rotation of the spine, side flexion, flexion of the hip. So this joint is really on the crossroad between the spine and the hip. And obviously, the tests that will stress the joint are the ones that provoke this, go behind the active movements and can induce some stress in the joint and cause some pain. What are the causes for dysfunction? Obviously, first one is hypermobility that can come from trauma, injury of the ligaments, high impact injuries like MVAs, fall, repetitive trauma from heavy weightlifting in sports, insufficiency fractures in older patients. And as Mohammed was saying, previous lumbar surgery. And we always think about the adjacent segment disease as the segment above your long construct, but below the sacroiliac joint is the next joint that can be attained by adjacent segment disease. Obviously, everything that comes with pregnancy, hormonal changes, the ligaments can slacken, can be stretched, and there is also this kind of risk factors associated. The other big cause is degeneration, which causes structural abnormalities related to wear and tear, to stress. And whenever you have gait patterns that are not normal, spine deformities, leg length discrepancies, this will cause some sort of repetitive stress on the joint and will cause damage of the joint. And you can have osteoarthritis, which increases with age, obviously also with previous lumbar surgery, not only hypermobility, but also can cause direct degeneration. And it can go from figures to 40 to 75% after 5 years. And last but not the least, inflammation, sacroiliitis, which is common in infections like brucellosis and inflammatory bowel disease, and all the seronegative spondyloarthritis. There have been not so many papers about this, but when we do long fusions in lumbar spine, thoracic lumbar spine, for adult deformity, spine deformity, I don't think most of the surgeons will think about sacroiliac pain or dysfunction at the time of the operation, of the index operation. And actually, 30% of those patients already have some sort of pain and degeneration of the sacroiliac joint that we don't actively look for it. IBMA, patients without lower lumbar spine segment lordosis, either pre-op or undercorrected, high pelvic incidence, whenever you instrument above L3, high-grade spondylolisthesis, increased SVAs. The type of the screws that we use, you can decrease a lot, obviously, the sacroiliac dysfunction if you go S2 alar iliac screws. So these are things that are coming out. We don't have really good literature on that, but here and there, some papers identify these problems as prone to cause dysfunction. So the big question here is how often is low back pain not coming from the back? And this study, landmark study from David Polly, looking at 200 patients, only 65% of the patients had spine-only pathology, like 8% hip, a mixed hip and SI joint pathology without spine pathology. 10% we could not figure out where was the trigger of the pain, and 12% hip pathology and 14.5% SI joint pathology. So there is, according to the literature, an important prevalence in cases of chronic low back pain and lower extremity pain that can reach up 1/3 of the patients. And I don't think we think a lot about this differential diagnosis when we see our patients in clinic. And this can really be a very debilitating condition. Most of the patients have ODIs above 50. The decrement in quality of life due to sacroiliac dysfunction is equivalent or even superior to other types of lumbar stenosis or spondylolisthesis. It's really, really impactful on the quality of life of the patients. However, one has to be cautious because SI joint degeneration increases incremental with age, and you can have figures like 90% of degeneration once you have 90 years old. So be careful. Not everything from this lecture on will be sacroiliac joint. So you can have some sort of degeneration in 30% of patients of subjects, and they are asymptomatic. So caution when you think it's a sacroiliac joint pain when you're seeing the patient. So this leads us to the diagnosis. And what is really important when you ask to the patient, tell me exactly where is your pain coming from? And they are able to spot an epicenter 10 cm caudally and 3 cm laterally, the posterior superior iliac spine. This is called 14-finger test. Patients can really point where the CAM is, where the epicenter of the pain is. But they can have referred pain to abdomen, to buttocks, to lower limb region, groin, the posterolateral tight, usually one leg. Type of pain can be sharp, dull, shooting, can be sometimes misdiagnosed as a radicular pain. It's aggravated by standing from seated position, prolonged standing or sitting, climbing stairs, lying on ipsilateral side. It's typical to have some sort of pain during night, and also numbness and tingling in the legs may be present. And I advise you to learn this scale, the Denver SI Joint Outcome Scale, to better classify the pain and the origin of the pain. As you see, diagnosis is not easy. Pain patterns are variable and consistent with other hip and spine conditions. So what we should do? We should do provocative tests to confirm SI joint as a pain generator. And most of those tests include distraction of the joint, distraction and compression. And these are the most relevant tests. No single test is diagnostic. You need more than 3 positive tests to start to think about an SI joint origin for the pain. And the sensitivity is around 87% for positive response if you have 3 provocative maneuvers that are positive. And these provocative tests that stress the SI joint are predictive of a positive response to image-guided intra-articular block. If at least 3 maneuvers are positive, your blocks will be very likely also positive. 85% of them will be positive. This is a very interesting study with 40 patients, double-blind trial, patients with SI joint with three provocative tests positive. They gave 4 milliliters of 1% lidocaine versus 4 milliliters of normal saline in the painful joint. None of the saline suppressed to any significant degree the pain. So three provocative tests were highly predictable value for pain arising from the SacroIliac pain joint, with a specificity of 100% for each test and a very good sensitivity. And these are the tests: Faber, Geinslin, distraction, tight thrust, and compression. You should get familiar with them. What about imaging? And for us that do private medicine, it's insurance companies always ask for reports that correlate with the pathology. And here it's going to be very difficult because CT and MRI have very low sensitivity and poor correlation with symptoms, except high specific for spondyloarthritis. Nevertheless, they are important because they can exclude other causes of pain, like osteoarthritis in the hip, like L5S1 degeneration. So MRI and CT doesn't bring you the diagnosis of SI joint pain, but can rule out related complications or neighbor complications. So what you should do is a fluoroscopic guide percutaneous SI joint block with a local anesthetic lidocaine, which is the most reliable method for diagnosing. And I always do my blocks with some sort of arthrogram confirmation. A paper here, again from David Polly group, with more than 300 patients, 6 and 12 months improvements of SacroIliac joint with intraarticular blocks. And the criteria for the reduction to value an intraarticular block was more than 50% reduction, a threshold of more than 50% reduction of the pain within 1 hour is associated with an excellent outcome. So we have our suspicion of pain, we have done our provocative tests, we have done our intraarticular injection, and we have the diagnosis. So we need to think about treatment. Like in every condition, you start with pain medications, physical therapies, steroid injections, radiofrequency. But what we know is that pain medications, they afford a very temporary relief of pain and disability. They have no impact on the underlying disease process. And obviously, you risk to addict patients to opioids, which is a major public health concern, at least in the US. And effectiveness of physical therapy in chronic SI joint dysfunction has not been demonstrated. The only exception is SI joint pain related with pregnancy. And there was a randomized control trial done that 1 year postpartum showed that significantly lower pain intensity and disability in those submitted to some form of physical therapy compared with the control group. Radiofrequency is a hot topic, mainly for non-surgeon doctors. Studies are done, lateral branch neurotomy, 3 months follow-up. A lot of those studies are really short follow-up. They have a very short follow-up. 1 year follow-up on one of these studies from one radioablation trial showed a really modest pain reduction. And you can see here 1 year follow-up, only 2 patients, 14% of patients in the treatment group with radiofrequency demonstrated a persistent pain relief. So painkillers, physiotherapy, radiofrequency are probably not the definitive treatment for this kind of problem. What are the predictors of failure for radiofrequency? The intensity of pain that you have before radiofrequency, if you are an older patient, if there is some sort of pain radiating below the knee, if you take regular opioids, and it seems it seems that if you do conventional radiofrequency, you have less success than if you do cooled radiofrequency. So we are left with the option of surgery. And many years ago, open surgery used to be done for this problem, the SI joint, chronic SI joint pain, but it was really a very invasive surgery with gluteus mobilizations and really tough surgery. That's why there is so big difference when you compare in trials the open surgery with MIS. In 24 months, 47% versus 82% in reduction of pain. As you see here, clear difference in percentage change of ODI with the procedures, but it reaches MCID when you do it on a MIS way. If you do it open, extremely invasive surgery, blood loss very high, length of surgery really big, and length of stay more than 3 days. Whereas the cases that I do on MIS, they stay overnight and they can be discharged the next day with really minimal blood loss. Also, if you do it open, you have more prolonged postoperative rehabilitation. You probably have better fusion rates because you can do a direct curettage and bone grafting, but you have more complications, and it has been abandoned as a routine procedure for chronic SI joint dysfunction. There are a good number of studies, randomized studies, good evidence, level 1 studies on the efficacy of MIS SI joint fusion, improving pain, function, and quality of life. These are some of the studies. There are many approaches when you do MIS fusion as SacroIliac fusion. The most common is the lateral transiliac. That's the one I do. You can have the posterior transiliac. Basically, you go from a more posterior approach, or you have the posterior interposition. And they are really not so much performed, as you can see here. PLTI, 7% of the cases, and PI, the posterior, around 15% of the cases. All the strong evidence that exists in the literature comes from the lateral transiliac screws. A large improvement in pain and disability compared with the posterior approaches, like we see this in this systematic review and meta-analysis. Different type of devices, different companies come with different types of devices. We have to acknowledge that the most robust literature exists for the triangular shape devices, and there are also a lot of devices that they come out, they are used, and there is no relevant published literature about them. Improvements in pain and disability are really higher in the lateral implants and lower in the other procedures that I show you. So basically, you have this kind of triangular implants. Company who produces them claim that there is some sort of biomechanical advantage because they don't rotate. There is no really graft placed inside the joint, and fusion relies on bone ingrowth across the porous coating of screw, and then you can have this kind of cannulated screws, rounded screws. They cannot resist so well to rotational motion, but either one or the other, they can provide short-term stabilization, and this is enough to cause really an improvement of the pain, and follow up by long-term fusion that can be assessed by CT most of the time. The 2 years outcome of this randomized control study, 148 patients. These were patients with a really high baseline pain rating, 90% not working, 2/3 of the patients were under opioids. So the duration of the pain prior to surgery was 6.4 years. and 40% prior lumbar fusion. So really bad patients. They started with really bad patients. Most of the patients were unilateral. The mean time procedure was 45 minutes, which is really what we take. Fluoroscopic time 2.5. Blood loss is vestigial. We insert 3 implants in most of the cases. From a biomechanical point of view, it's much more sound. Mean hospital stay, it's 1 day. If you have comorbidities, you can prolong it. In the SI joint, one failure due to inadequate pain relief or symptomatic implant malposition, and the non-surgical group, all primary endpoints failure were result of inadequate pain relief. So definitely there was a big advantage, substantial advantage of doing MIS fusion versus non-surgical fusion. The mean SI checkpoint score improved, as you see here, from important baseline 82 to 26. Again, you see, and what was interesting to see either in this trial was that there was patients crossing over. The disparity of the outcomes were at early follow-up so different that some of the patients crossed over from the non-surgical group to the SI joint fusion group. As you can see here, VAS, ODI, and even the patients that cross over from, which means that they were not offered surgery immediately, they had a similar improvement as the ones who had benefit from surgery since the beginning of the study. Significant improvement on ODI at 2 years, which is really similar to most of the surgeries we do in the lumbar spine. Mean improvement of 28 points on ODI, which is probably bigger than it's reported in the SPORT trial for degenerative spondylolisthesis and lumbar stenosis, but still an improvement a little bit lower than lumbar disc herniation surgery, microdiscectomy. So this is just for you to value in terms of the outcomes that you know from other pathologies that you currently treat, what you can expect, the benefit you can expect in those patients. Quality of life, also interesting, a remarkable decrease on the opioid intake, the patients that were operated. What were the predictors on this study that of patients know where pain was not improving significantly? Whenever you treat bilaterally, whenever there is a history of lumbar fusion, smoking, heavy use of opioids at baseline, pain beginning in the peripartum period, age, and body mass index has some influence. Satisfaction rate were really high compared the 2 groups, 77 for MIS, SI joint fusion, 27 for the non-surgical group. On this systematic review and meta-analysis, they conclude that MIS SacroIliac joint fusion is cost-effective when compared with conservative treatment options. Again, this meta-analysis relevant improvements of VAS, ODI, patient satisfaction, opioid use, there is no doubt about this. In terms of adverse effects, no big difference. The safety profile, it's a total of 819 joints fused, 11% complications related with the procedure. Most of them are wound infection and drainage, hematoma formation, and you can have around 2% due to malplacement of the implant. And the nerve root impingement can happen in 13%, in 13 cases of all these more than 800 cases done, and the revision rate of 2.5. And most of the complication is L5 radiculopathy, whenever the superior implant can violate I would say the joint upwards and touch the L5, the descending L5 nerve roots. The 5 years cumulative rate of revision was 3.6%. And so what is really interesting and difficult is what you do if you have a screw malposition. And this can be a problem because salvage revisions can be very, very challenging. So before you starting doing these procedures, you have to have really good training in cadavers or look for mentoring or call experts for your first cases, because if you insert a screw that it's not in a good position and is causing any sort of clinical impact, it can be challenging. Again, cost effectiveness is, if you compare to other type of treatments, SI joint MIS is comparable to knee and hip joint replacement. And on the other hand, if you not diagnose and you do inappropriate lumbar fusion for something that it's MIS, it's a sacroiliac joint, you have the cost and you have the associated comorbidities. So a lot of reasons to start to think about this pathology. Again, 5 years, a durable effect, 64% maintain a reduced ODI compared with only 4% of non-surgical arm. Again, so we start to doing this procedure, and just some preliminary studies on some of our patients, consecutive patients. We used 2 different devices, iFuse and the SI-lock. You work based on 3 incidents of the X-ray. You have to see the lateral view and the inlet outlet view. And if you don't see clear the lines, the anatomical lines, the anatomical landmarks, you should not do the procedure. Better not to perform, better to abandon the surgery. You rely a lot on this procedure, on 3D anatomy, and this is really important. This measure is really important. The LR line, you have to see it clearly, superimposed, the inlet view and the outlet view that you can get. We have done 18 patients, follow-up about from 3 to 37 months. Most of them were females. 56% had previous lumbar surgery, 17% had previous radiofrequency that was not successful. The length of hospital, it's a little bit hypertrophic here because it was really our first cases in the learning curve, and sometimes during the weekend hospitalization. We had 1 mispositioned screw that needed revision. Significant decrease on the ODI. The Quebec scores also really improved, standing up for more than 30 minutes and able to sitting in chair for several hours. Decrease on VAS, significant decrease also on the intake and of anti-inflammatories, of non-significant of opioids, because a lot of our patients, we don't put them on opioids even in pre-op conditions. This is a really interesting case of a man goalkeeper, football goalkeeper, 41, chronic low back pain, irradiating left buttock and groin. Really very, very painful patient, as you can see here. And after we done the operation, a remarkable reduction of the clinical indexes, and he start to resume sports 3 months after the surgery without any medication. And you can see here the positioning of the implants on the coronal CT. If the implant is here too high, that's where the problem comes with L5 nerve root. Here, another female, also again very off medication and start to work very briefly. Nevertheless, we have to be cautious because the good studies that you have, and we have here 14 studies that were considered, half of them received strong industry sponsored funding. And at least in half of the studies, one author had significant disclosures to present. So we need to value this. A lot of that data is very robust data, but it comes from half of them. It comes from industry sponsoring fund, and we have to always be cautious about that. So what are my indications for MIS SI joint fusion? Significant pain, ODI more than 30, VAS more than 50, that impacts significantly on the life of the patients and limits daily activities. Failure to respond to 3 to 6 months of non-surgical treatment with maximized steroids, physical therapy. Then we have to combine at least 3 physical examination maneuvers that can reproduce patient typical pain. And once we have that, confirmation of the SI joint as pain generated by reduction of 50% of pain with a diagnostic intra-articular block. And obviously, other alternative diagnoses like lumbar stenosis, disc herniation, knee problems should be ruled out. So, in conclusion, I think that it's SI joint. It's an overlooked pain generator in chronic low back pain, in part because it mimics hip and spine conditions. If you want to diagnose those conditions, you have to have a high suspicion rate in the differential diagnosis workup, especially patients with previous lumbar fusions. The protocol, the diagnostic protocol that you follow should be very, very strict. Always 3 provocative maneuvers, arterial blocks with more than 50% decrease of pain. It's worse to do it. You have a significant successful reports on the literature about reduction of pain, more than 80%, and it's a durable treatment. We have now follow-ups for more than 5 years. It shows clinical superiority to open surgery, which has been more or less abandoned, less tissue damage, less blood loss, less duration of hospitalization. The effect of implants, shape, number, positioning on long-term outcomes are not yet fully understood. So I believe that this technique can be a potential standard in treatment of chronic SacroIliac joint pain that for more than 6 months that it's not responding to conservative treatment. As you follow a very strict protocol, I can tell you this is one of the most pleasant surgeries that I can do for patients. They are really, really satisfied. Thank you.
Thank you so much, Dr. Oscar. It's a great presentation. I think that you brought up some very important points. I think we have one question in the chat before I ask some questions. The question from Harshad was, do you encounter tubercular SI joint infection?
No, I would not advise it to do it. Definitely, it's not a good indication.
Okay. My questions to you, Dr. Oscar, is number one, first of all, great presentation. Should those provocative tests, do you think, be part of the standard physical maneuvers for all patients that come with spine pathology? As you said, David Pauly's group showed that there's such a big overlap. Do you think that we should be doing these provocative maneuvers on every patient?
Absolutely. During my neurosurgical training and career as a consultant, I never heard about SacroIliac joint pain as really meaningful. We are not exposed to that. Okay, so once we start to webinars like this or go to cadaver labs, listen to talks, that's when you become aware, and you don't think that this pain exists at all. I mean, you think this is not real. But then when you start to incorporate systematically those tests in every single patient that comes to you with a low back pain, you will start to see the problem. So to answer clear to your question, Mohammed, I think you should incorporate in your physical examination all these tests in all patients.
I totally agree.
You will be a much better surgeon and doctor.
I totally agree. If I could ask one more question, what is the role of advanced imaging, whether it be CT SPECT or MR SPECT or any type of functional type of imaging? Do you have any experience with that? And
Right.
what are your thoughts?
I don't have personal experience. We don't do routinely specs but I think it can be useful for arthritis, for some inflammatory conditions. But this you can have blood tests as well. I know that some of them are seronegative, but most of these problems are due to hypermobility. You do CTs of the SI joint and they don't find any abnormality. And it will be very difficult for imaging to show up anything. And as I said, there is almost no motion in this joint, but which is 1 to 2 degrees. But if it moves 4 or 5, that you cannot show in any MR, in any X-ray or whatever, it will cause really lots of pain, very intense pain. So hypermobility won't show up in any study that I know. So you have to rely a lot on your clinical skills. I think and I think you mentioned, or in terms of what could be this surgery in terms of navigation. I think this would be the easiest operation for a robot to do it. It's really simple. It's really simple, a robot that could do from A to Z this operation. You just probably need to make an incision and a robot could do the rest. So that's certainly a field we can develop.
Yeah, my partner, Dr. Khoi Than, published a paper on robotic SI joint fusion, and it's very
Yeah.
feasible, and I think it's
No.
very, very doable.
Yes, yeah. I mean, contrary to other surgeries that we tend to bring robots here, it's the ideal robotic surgery, in my opinion.
Absolutely. Great. Just also for the attendees, you have to be careful about other complications. We published about a very rare complication, a superior gluteal artery pseudoaneurysm that happened. So you have to be very careful when you're making your access not to injure some of the arterial supply. So that's another thing.
I didn't talk about that because it's if you are really careful, it shouldn't exist. The biggest complication is really L5 radiculopathy because you have this incisura can be very low, and then you don't have space to insert the 3 implants, and then you tend to go a little higher in the joint, and that's where you can face the L5 nerve root. And we had one problem like that. That was solved with taking out the screw. Unfortunately, it was not one of those triangulars, was the screw type, and it was easier to unscrew it. And the patient fully recovered.
Okay, great. With that, I think Dr. Raja will hand it over back to you.
Thank you. Thank you, guys.
Thank you so much.
There
I
are
have one question.
questions? Yes, sure, Professor Sugara.
Thank you very much for your great lecture.
Thank you.
Actually, I'm not familiar with this field, but you show the X-ray with the only one side fixation insertion. So I'd like to know the one side insertion is enough, and how do you decide the side you insert the implantation?
Yeah, I mean, that's a good question. I think clinically, most of the patients have unilateral pain. They can tell you in the finger point test exactly where the pain is. And the majority of patients have just unilateral disease. And that's why we do most of the cases just unilateral implants. In cases where you have bilateral, I always clinically bilateral with proven injections, everything. I always do one side, the worst side first, and then leave it for a second time to do the other side. So I'd never do both of them at the index surgery. And it's also a matter of debate if by doing one side, you will get some degeneration and pain on the other side. We have to think about that. We don't have literature on that. So we are really far away from having an idea if we need to do any prophylactic bilateral immediately fixation. So What I do is I treat what I get, what I see, and most of the patients have unilateral disease.
Thank you.
Thank you.
Thank you very much. One question that I would like to ask is like, do you always try the blocks along with a dose of steroid in your treatment?
Right. So we as I said, what I explain to patients, you have a sacroiliac joint pain, and in reality I have three patterns of patients, and besides lidocaine, I also inject some sort of steroids. And fortunately, a lot of those patients, they do well for a long time. And if pain goes away, I don't offer a sacroiliac joint fusion right away. So I have patients that I never see again because they have done good. I have more patients that come with pain, like 1 year, and then you can consider repeat the block. Or the one I do, the MIS fusion is the one who comes with pain, let's say a week, 2 weeks after the blocks. And this is the ideal candidate for the surgery. This kind of patient will feel a real benefit from the surgery.
That's right. We also see a lot of patients in our practice like this when we give a dose of triamcinolone along with the bupivacaine. They get immediate relief for a couple of months and they return to you after 6 to 9 months. And another thing is that MRI is a very good diagnostic tool when there is a bone marrow edema on stir images that will give you an idea about the inflammation in that joint.
I absolutely agree. But a lot of those patients, they don't have any structural problem in the joint. It's hypermobility. So my message here is not the fact that an SI joint MRI or CT is normal, that you can rule out this diagnosis. Okay, that's my message.
Thank you. Any questions from Liu?
Thanks, Prof. Oscar, for a very comprehensive lecture. I would like to ask a simple question, Professor. I want to know why the term dysfunction is used when we are talking about fusion, whereas in other fusion surgeries, we're talking about mechanical instability, and dysfunction term was used. It's used for this. Second question, Professor, regarding women with childbearing age, are they contraindication? My third question, Professor, in revision surgery, whether due to persistent pain or due to recurrences, where we cannot perform any more provocative tests, how do we decide on revision, or there's no such thing of revision surgery in those patients? Thank you, Professor.
Right. Just to start by your last question, I think it's very rare if you follow a very strict protocol that I try to explain here, that you have recurrence of pain if you have done a proper surgery, if you have implanted 3 implants, which gives this primary stability. I think the last question you're answering, you are asking me is really an unreal scenario. I've not faced any of those situations. And I think you should really follow this strict protocol. Be sure that the pain comes from there and that you have ruled out hip and lumbar problems. And if you do a proper surgery, I don't see why you will face scenario number 3. Your second question was about pregnant women?
Yeah, a young woman, childbearing age. Should we do surgery or not?
It depends once again on the intensity of pain, how confident you are with the diagnosis. We have done it. It's not probably the most common population, but it's possible to do it, yes.
And how about the term dysfunction? The term dysfunction used compared to mechanical instability.
What you mean term I can't.
The term dysfunction in most paper publication, the fusion because of dysfunction, whereas in other fusion surgery we talk about instability. Why so?
You mean instability of the joint?
Yeah, why the term dysfunction is used in this terminology of the treatment?
Right. When you talk about fusion, MIS fusion of the SI joint, it's not really fusion. You don't see, because of you're not decorticating the joint, you're not introducing a graft. It's not really a big fusion that you see. I'm convinced that most of the reason why the pain goes away is the stability, the mechanical stability, the primary stability that you can afford with the implants. Obviously, over the years, you can see some ingrowths, but there is no this criteria of fusion, as you can see when you're performing an ACDF or a TLIF, or it's a different concept. I think most, and the case I've done, I think most of the benefit comes from primary stability. This is that's why I think it's important to insert 3 implants and not 2, and certainly not 1. 1 doesn't make any difference, in my opinion.
Thank you, Professor.
Okay.
Well, thank you very much. I would like to thank both the speaker and chair, Professor Oscar Alves and Professor Mohammad Abdul-Baha, for this wonderful session on sacroiliac joint, which is in fact indeed a very neglected topic. So I would like to mention to our viewers that this is being broadcasted on WeChat, YouTube and Zoom. Thanks to Professor Shubin. We have around 540 people live who have joined us for this event. Now we'll move on to the second session, and I'll hand over this podium to Professor Takashi Sugawara, who will say a short introduction about surgery for cavernous sinus tumors, and invite Professor Shiale for his lecture. Professor Sugawara.
Okay. Today, this time we have Professor Xiaoliu Lei from China, and he will be talking about the surgical management of cavernous sinus tumors. And as everyone knows, the cavernous sinus surgery has been thought to be a high-risk surgery, and we call it a kind of no man's land, and because there are some critical structures in the cavernous sinus. And in 1980s and 1990s, surgical outcome were extremely poor. So since then, radiosurgery has become the preferred treatment for all this area. But however, Dr. Christ has recently shown that the tumor in the cavernous sinus can be safely resected when we well understand the anatomy, and cavernous sinus surgery is getting more widespread around the world. So I've been looking forward to hearing today's lecture from Professor Xiaolei. So are you ready? Could you start your lecture, please?
Hello, everyone. Happy to hear for the presentation. I'm Xiaolei, come from the first affiliated hospital of Wenzhou Medical University. Here is our operation team, including Professor Zhuge, Professor Yang, and me. The topic is surgical treatment of cavernous sinus tumor. As we know, the common types of cavernous sinus tumor, including schwannoma, meningioma, pituitary adenoma, and the cavernous hemangioma. Let's talk about schwannoma firstly. This is a case of a 28-year-old male diagnosed with schwannoma. This is the actual view from the contrast-enhanced MRI, indicating a large schwannoma located in the cavernous sinus. This is the contrast-enhanced coronal MRI scan, in which the ipsilateral internal carotid artery is not visualized here. Such imaging pattern is commonly seen in meningiomas. We even believe it is a meningioma preoperatively. However, it is also possible that a firm schwannoma is compressing the internal carotid artery, leading to its conclusion. This tumor size is large, and in order to achieve adequate exposure, we adopted a classic frontotemporal transdogmatic approach. This approach is a well-established technique for managing tumors in the cavernous sinus, allowing access from both lateral and anterior directions. This is particularly suitable for large and firm tumors. Shown here is the surgical incision designed for this patient. We opened the lateral wall of the cavernous sinus and found the tumor was very firm, but well demarcated. so it is a typical schwannoma. During debarking process, the tumor was removed piece by piece. And eventually, the internal carotid artery was identified, and the tumor was completely removed. Here we can see the internal carotid artery. The post-operative MRI confirmed the complete removal of the tumor. This is another typical schwannoma. As for this smaller size, the presence of significant system components suggests a softer consistency, making it suitable for internal compression. Therefore, we aim to adopt a less invasive strategy. Our surgical plan is to proceed with a total epidural approach, specifically the Dolenc approach. This image illustrates the anatomy structure of the lateral wall of cavernous sinus. The wall consists of two distinct layers, the outer layer and the inner layer. Notably, the outer layer is significantly thicker than the inner one. Beneath the inner layer, several cranial nerves can be visible within the cavernous sinus. After classical frontal temporal craniotomy, we can peel off the outer layer to epidurally expose the tumor. As the same strategy, after debarking the tumor, we dissected around the tumor's capsule. And in the end, we found the tumor-bearing nerve. After cutting the nerve, we can remove the tumor totally. The eye appear normal after surgery, indicating that the critical motor nerve within the cavernous sinus were well preserved. This case involved a 41-year-old female. She is a designer. The schwannoma was located anterior to the cavernous sinus, near the superior orbital fissure, giving her high demands for neurological function and her strong desire to restore normal visual capacity. We choose to proceed with the Dolenc approach to maximize preservation of the neural function. These are contrasting images in sagittal and coronal views, respectively. Similarly, through the Dolenc approach, we peeled off the lateral layer of the lateral wall of cavernous sinus, achieving excellent exposure of the tumor. The tumor was dissected along its capsular plane, similarly to the technique used in vestibular schwannoma resection, in order to maximize preservation of the normal neural function. In the end, after the tumor were removed, we can see the tumor-bearing nerve. Here is the tumor-bearing nerve.
好的，我在网上找到了这个与中蒙臂丸拿有关的。
The postoperative MRI scan showed that the tumor was totally removed. On the first postoperative day, the patients exhibit normal eye movement, and her diplopia remained unchanged, neither worsened nor improved compared to pre-operative level. 2 weeks later, she contacted us via WeChat and happily reported that her diplopia was gradually improving. By 1 month postoperatively, he had fully retained her original duties as a designer. 往上看，往这边看，往这边看。This is another case of schwannoma located more anteriorly, with partial extension into the orbital. Contrasting enhanced MRI revealed 2 orbital tumors, 1 large and 1 small. CT bone window image revealed an enlarged superior orbital fissure, indicating that the tumor extends through the fissure, establishing communicating between the cavernous sinus and orbit. For this type of craniotomy, cranio-orbital communicating tumor, we selected an orbital dramatic craniotomy combined with the lung approach. This is the surgical show how we perform the modified orbital zygomatic craniotomy. We take the interfacial method to preserve the facial nerve branches. Then we exposed zygomatic arc totally. And we can see the supraorbital forerunner. Then we cut temporal muscle and flapped inferiorly. This photo shows the site of burr hole and the bone cutting root. The keyhole can expose the dural and the orbital fissure, both. Then we make a keyhole and expose dural and the orbital fissure. Then we make the burr hole and cutting the bone step by step. Finally, we cut root of orbit. This last step. Then we can elevate the bone flap. Then craniotomy was complete. This is extend frontal temporal fissure with single piece frontal orbital bone flap. After orbital zygomatic craniotomy, we peeled off the outer layer of the lateral wall of cavernous sinus to expose the cavernous sinus tumor. Here is the tumor in the cavernous sinus. And the left side is the anterior clinoid process. Then we drilled off the lateral orbital bone wall. Incise the orbital fissure to reveal the intraorbital portion of the tumor. Then the common tendinous ring was opened. We cut the common tendinous ring. Then the tumor was totally removed. This is a large case of cavernous sinus orbital communicating schwannoma, for which we also employ an orbital zygomatic craniotomy combined with the Lank approach. This is a sagittal view on MRI. We firstly peeled off the outer layer of the left wall of cavernous sinus to expose the tumor within the cavernous region. Next, the lateral orbital wall was drilled off. Then the cavernous portion of the tumor was resected firstly. We then incise the orbital fissure to expose the intraorbital tumor. The intraorbital tumor was carefully dissected. Some tumor-bearing nerves were transected, allowing us to mobilize the intraorbital component to the cavernous sinus space. So we put the tumor into the cavernous sinus space and remove it piece by piece. For the most adhesion portion that could not be put out, we returned to the orbit, transected the remaining tumor-carrying nerve. And ultimately achieved complete resection of the tumor via the cavernous sinus corrida. And then we can find the cavernous sinus space and the orbital space is communicated. Post-operative MRI showed the tumor was totally removed. Another common type of tumor is mesothelioma, which presents a significantly greater surgical challenge compared to the schwannoma. This is primarily due to the lack of well-defined capsule, and the extent of resection often depend on consistency of tumor, whether it is soft or firm. This case involved 49-year-old female presented with light eye pain and diplopia 1 year. The high signal on T2 weighted image suggests that the tumor has a soft consistency. And this is the contrast-enhanced MRI, axial and coronal image. Due to the relative soft consistency of the tumor, we adopted the Lenk approach. Similarly, we peeled off the outer layer of the lateral wall of the cavernous sinus to expose the tumor within the cavernous region. The tumor was found to have a relatively soft consistency, allowing for gradual aspiration with suction. During the procedure, vital vascular and neurovascular structures within the cavernous sinus became clearly visible. Ultimately, the tumor was completely resected. This is the post-operative MRI scan, confirmed the tumor was totally removed. This is another case involving a 48-year-old male presented with right-sided facial numbness for 6 months. This is a case of petrocerpax, cavernous sinus meningioma. Axial image revealed that the tumor involves the petrocerpax, cavernous sinus, and the macrocaves. The tumor also involves the upper clivus. And we can see that the main portion of the tumor within the cavernous sinus is located lateral to the internal carotid artery. Here, lateral to the internal carotid artery, you can see. We adopted a subtemporal anterior protrusive approach. The procedure began with open the macrocave and resecting the tumor within it, which was found to be very extremely firm in consistency. So we remove the tumor of a microcave. Then we'll proceed inferiorly to the oculomotor nerve to remove the portion of tumor within the cavernous sinus. This is the oculomotor nerve. We remove the tumor beneath the oculomotor nerve. And the tumor involved the trochlear nerve was cut. And this is the trochlear nerve being cut. Thereafter, remove the upper clavicle component. Then we can see some normal neurovascular structures. This is the pituitary stalk and oculomotor nerve. And this is the basal artery. And this is the contralateral oculomotor nerve. Finally, using an ultrasonic aspirator, we gradually remove the tumor located in the cavernous sinus lateral to the internal carotid artery. As resection progressed, we note the change in tumor consistency. If it becomes softer, that indicates adjacent to the internal carotid artery. Here we can find some pulsation indicate adjacent to the internal carotid artery. Residual tumor on the surface of internal carotid artery was coagulated using bipolar. And this is the trigeminal nerve. This is patient post-operative MI scan showed the tumor was totally removed. Coronal image. The patient did not undergo radiosurgery post-operatively and has been followed up for 5 years without any sign of recurrence. Another type of tumor is invasive pituitary adenoma, for which we routinely employ an extended transsphenoidal approach. In this particular case, the tumor encased internal carotid artery. However, the tumor that envelop the internal carotid artery typically have a softer consistency, making resection less challenging compared to meningiomas. This is the coronal image, sagittal. We employ an extended transsphenoidal approach, which allow for full exposure the anterior wall of the cavernous sinus. The dura was widely opened, and the tumor has a relatively soft consistency. And we gradually aspirate the tumor around the internal carotid artery. And this is the anterior inferior space. And this is the internal carotid artery. Then remove the tumor in the posterior superior space. This is the post-operative MI scan, indicates the completely tumor resection. This is another pituitary adenoma case with greater invasiveness. We adopted the extended transsphenoidal approach, including resection of the pterygoid process to expose the lateral recess of the sphenoidal sinus and assess the tumor. During surgical procedure, the internal carotid artery was fully exposed. And after tumor removal, some cranial nerve within the cavernous sinus can be seen. Post-operative MI scan showed the tumor was totally removed. The last type of tumor is cavernous hemangioma. We also encounter cavernous hemangioma for these that are small in size and located immediately. We employ an endoscopic transsphenoidal approach for resection. This T2 and T2, this T2 image, and this enhancement. In this case, the preoperative diagnosis was suspected to be a pituitary adenoma, but intraoperatively, The lesion was identified as cavernous hemangioma. The tumor has a complete capsule that can be dissected along the capsule. And as we dissected and coagulated the capsule, the tumor shrinked. In the end, we can totally remove the tumor. After surgery, the patient's eye movement is free. Post-operative MRI scan confirmed the tumor totally removed. And the pathology report also supports the lesion is cavernous hemangioma. With the advantage of endoscopic techniques, we now routinely assess the feasibility of transnasal endoscopic approach for cavernous sinus tumor. In this particular case, where the Dolenc epidural approach would have previously been considered, we successfully achieved tumor resection via the transnasal route. With the endoscopy, we drilled off the pterygoid process, which allowed direct exposure to the tumor. Intraoperatively, the internal carotid artery was found to be displaced medially by the tumor, consistent with the findings on preoperative CTA image. Here is the internal carotid artery being displaced medially. Post-operative CT image demonstrated the surgical corridor. Post-operative MI confirmed complete tumor resection. This is the coronal and sagittal image. And the patient's eye movement is free. Okay, that's all. Thanks for your attention.
Thank you very much for your great, many beautiful surgery cases. Any questions? We have two questions from the chat. Like one is, do you always remove zygomatic arch in craniotomy?
No, I usually use transdiagnostic approach for large tumor, especially extend into middle fossa. But for small tumor, we don't use transdiagnostic craniotomy. We only use classical frontal temporal approach. That's enough.
Yeah, actually, I agree with you. But even if the tumor is big, for me, I usually use only the classical front temporal craniotomy because this type of surgery is kind of look down surgery. But it depends on how you feel comfortable. And another question is which cases use subject for SRS?
Uh, uh, for some patients need stereotactic radiosurgery. Many of these patients is meningioma that cannot be total removed because the tumor is firm and hard to total remove. We only take the partial resection, and residual tumor can be controlled by the radiosurgery.
Okay, then
Right.
actually, also I have another question. Like, what is the surgical indication for this kind of tumor in the cavernous sinus?
For some tumor in the cavernous sinus, the tumor is firm and have not clear margin around the vascular and neurovascular structures. We may take the portion resection strategy.
I mean, for me, my surgical indication is especially for the meningioma. I think the patient has some kind of symptom like the diplopia or visual deficit. So I think at least the decompression of the third nerve, sixth nerve, and the optic nerve is I think a kind of indication for the surgery for me. So how about your thought?
For schwannoma, if the patient have no symptom,
Mhm.
we may suggest wait and see is a good choice maybe.
Mhm.
And if he had some symptom and the tumor such where invaded the tumor or invaded the nerve or cavernous structure, such as meningioma. We maybe suggest to make some method to control the tumor's growth.
And I mean, how about the facial numbness? I mean, in my experience, it is very difficult, hard to restore the fifth nerve function. I mean, improve the facial numbness is very difficult, but also sometimes the worsen the symptom of the fifth nerve. how do you think you think you can restore the fifth nerve function by the surgery, decompression?
No, it's very difficult to relieve his symptom, such as numbness. The surgery is only to stop the tumor's growth and to save other cranial nerve function, such as eye movement and optical capacity.
Okay, then another question is, can you tell us how to stop the bleeding from the cavernous sinus? What kind of materials do you use?
Cavernous sinus in normal cavernous although a normal cavernous sinus is filled with blood, but when the tumor grows in with it, the venous perplex is often compressed and does not bleed. If bleeding occur during tumor resection in the cavernous sinus, that often indicate that tumor in that direction was already being removed. Typically, we began resection the cavernous sinus tumor from a relative safe direction to compress the area until reach the tumor's boundary. If bleeding is encountered, we use a gelatin spoon and a cotton pad and to compress for a second. Then we can stop the bleeding. Then we continue to dissecting along the bordering until the tumor was totally removed. The bleeding from the cavernous sinus is effectively controlled.
Do you use like a fibrin glue or injection or the flowable hemostatic materials?
Yes,
I mean, in addition to the cavernous sinus.
Yes, this is
Yes,
effective.
okay.
This is effective.
I agree. And one other question: you use the ultrasonic aspirator in your video, and looks very small tip of your ultrasonic aspirator. What is that? What the name of the tool?
Final cut.
Final cut.
Yeah.
Is this available all over the world?
You usually use Final Cut to make video.
It looks like very small tip and very effective. I usually use a Kusa or Sonopet.
Yes. This is a good tool.
Okay, thank you. There. Any question from?
Well, thank you very much. We can take questions from the house. We have Professor Borba also here with us. Prof. Borba?
I'm here.
Yes.
Hello.
I see my great friend, Dr. Oscar Alves here. Hello, Oscar. Yeah.
Olá, Luís, viva!
How are you? I was watching this presentation, Dr. Lee. Do you know, the most important of this presentation is to show that it's possible. During the past, in the 80s, when Professor Dolenk started to do the surgery in the cavernous sinus, the people say that's not possible. After everyone started to do it for every case, without understanding the disease, without understanding too much the anatomy, and to deal with the cavernous sinus became a very complicated area. But now we are seeing more and more people around the world doing a wonderful job. I see Takashi here, he's from Japan, he does a wonderful job in Cavernous Sinus. I saw his presentation in several places. Now I see Dr. Lee here and all these people that is showing. Because you have in the Cavernous Sinus pituitary adenoma, that is soft, you can remove. You have chordoma, that's the problems. The chordoma is not the soft invasion, is the bone that go to around and the spread. We have in the lateral wall that can invade the cavernous sinus or displace the cavernous sinus, the schwannoma in general, as beautiful videos that you just showed. And you have the meningioma that is completely different. And we need to divide the cavernous sinus surgery in meningioma and non-meningioma. Non-meningioma is completely different disease than the surgery is possible to do. You have hemangiomas also. It's possible to do, it's possible to get a great removal for non-meningiomas. For meningiomas, depends of the location, the extension, if the meningioma is coming from outside to the cavernous sinus or totally only in the cavernous sinus, that the approach could be completely different. We are doing surgery of the cavernous sinus in this more than 20 years, but now I'm learning more, I see that it's more possible to do. Cavernous sinus meningioma still is a controversy, especially when the tumor go to the superior orbital fissure. That's all the nerves are together. And you try to remove the tumor, you have a lot of deficit in the superior orbital fissure. What I do in the cavernous sinus meningioma, I do the peeling of the middle fossa, remove the wall, leave the nerve in place, open the triangle of the optic nerve, the fourth nerve, and always, the majority of the time, I leave some tumor around the ICA and around the superior orbital fissure. And just observe. Just observe. Sometimes grow, sometimes doesn't grow. Sometimes the growing is so is not so much, there is no symptoms, the patient live very well. And for very select case that start to grow for this area, I use the radiosurgery. But radiosurgery, with low doses, no radiation therapy, stereotaxic radiation therapy. We are seeing now with meningiomas of the skull base. See, they just published now, is when you use stereotaxic radiation therapy that they call radiosurgery, that is not radiosurgery. Radiosurgery, 1 or 2 shots. Now they're using radiosurgery, 10 shots, 15 shots is the name change. Radiosurgery is one thing, radiation therapy is different thing. In radiation therapy, they use the majority of the patient with meningioma of the skull base. This is bad. In 10, 15, 20 years, this will change. And remember, it's not cancer. The patient will survive 15, 20, 40 years. If you take a lady with 40 years old, if you radiate with 40 years old, with 55, 60, this lady will have a transformation or something wrong is happening with this lady, related to the radiation more than meningioma by itself. You see, but the important that is there is no area in the skull base that you cannot reach. You cannot treat, you cannot do surgery. But does not mean that you need to do surgery in everyone. The selection is very, very important. And sometimes the natural history of this meningioma is much benign than any kind of treatment. Wait and do it, wait and see. It's sometimes much better than do surgery and radiation therapy. You see. Okay, I talk too much. Thank you.
Thank you, Prof, for
Thank
joining
you.
us.
Raj, I just have a comment.
Please.
First of all, congratulations for the lecture. It's really a master that we saw operating. And I agree with most of Professor Borba said. That's really my approach. I'm known for spine, but I still do a lot of cranial-based surgery and intrinsic brain tumors. And my question is more on the need to do to take the zygoma and to do the orbitotomy, as we saw in many cases. I personally don't feel this is necessary. The best retractor you have for the periorbita is the lateral wall of the orbita. We see it all the time. If we remove the bone, you have to put a spatula retractor because all this is falling into the field. So unless you have tumors that go really high and you need to have an angle of attack from below to eye, or pathology, I cited basilar aneurysms that cannot be coiled or whatever. By routine I don't do orbitozygomatic surgery. It's just a comment.
Okay, good suggestion.
Yeah, just to complement this, when I start, I was doing cranial orbitozygomatic to everyone. And get smaller.
Yeah, absolutely.
Now I'm doing the classical Dolenk approach. That is pterygium approach, more removing the orbit, the clinoid, see, open the Sylvian fissure. See. Sometimes you need, sometimes you don't need. There is no one approach for everyone. See,
it's tailored to the need of the patient. Yeah, I agree. I agree, Luis.
Excellent.
Yeah, exactly.
Excellent.
Thank you for those wise words of wisdom. We learned a lot. Prof. Sugawara, we can take your concluding remarks.
Thank you very much for everyone. And I think I totally agree with Professor Borba's opinion. And Professor Borba, are you coming to Japan next week, right?
Yes, next week I'll be there.
I'm looking forward to see you here again and discussing about it.
I'll go to learn.
Okay.
Thank you very much. I would like to close this officially now on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Oscar L. Alves and Professor Shiale, as well as the chairs, Professor Mohammad Abdulbar and Professor Takashi Sugawara, and of course the President-elect of the WFNS, Professor Luis Borba, for the time and support for the ACNS webinars. A very special thanks to Professor Shubin for broadcasting this on the WeChat channel. And as I mentioned earlier, we have now around 545 people who have joined us live from all over the world. Thanks to my co-host Dr. Liu Boon Singh for joining me. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.